demonstrating that with us. No, we're not going to do any singing. Okay, and to those of you joining us online, you're very welcome as well. I am delighted that Professor Paul Taylor from the University College London is here to deliver the 2024 Teddy Chester Lecture. This is an annual lecture which was inaugurated in 2006 by Professor Kieran Walsh to commemorate the 50th anniversary of the appointment of Teddy Chester, who was the first Professor of Social Administration at the University of Manchester and the first Director of the Health Services Management Unit within the business school. And his works continue today in supporting the education and development of health service leaders through the Health Management Group. Previous lectures have been given by a number of senior and influential academics, policymakers, and opinion leaders, among them Dame Elizabeth Aniowu, Mark Britnell, Anita Charlesworth, Stephen Dorrell, Bernie Ferry, Jennifer Dixon, Sir Chris Ham, Joan Higgins, Ted Balmer, Martin McKee, John Rouse, Sir Simon Stevens, and last year's lecturer, Sarah Jane Marsh. A little bit about Teddy Chester now, for everyone who doesn't know. He arrived in the UK on the eve of the Second World War as a Jewish refugee from Austria. His interests were always grounded in leadership and management development in the UK, as well as internationally, and he was one of the architects of the NHS's National Training Scheme for Hospital Administrators in 1961. And that's a forerunner to the graduate training scheme that the Health Management Group now continues to have an active role in delivering. Now to our speaker, Paul Taylor. Paul has an academic background in psychology, medical physics, and artificial intelligence. He first worked on the application of AI in healthcare, I can't believe this, in 1989, using decision support systems to help in the management of chemotherapy protocols. First in France, and then at what was the Imperial Cancer Research Fund and is now Cancer Research UK. Paul's PhD was the use of decision support for the interpretation of mammograms, and since 1997, he's worked at University College London. In 2004, he wrote a textbook on health data science, From Patient Data to Medical Knowledge. He's the director of University College London UK RI Centre for doctoral training in AI-enabled healthcare. More recently, and this is how I know Paul, he's been an active contributor at UCL to the specialist education of graduate management trainees, specifically those undertaking informatics and analytics pathways, most recently in collaboration with Professor George Moulton from the University of Manchester. And I met Paul via his contribution to Healthcare Management 4th edition, which I've been co-editing for the past 2 years with Professor Kieran Walsh, Professor Judith Smith and Manny Sidhu from the University of Birmingham. And it's due out next year, so an early plug for it. So that's all the introductions done. Paul will speak for about 30 or 35 minutes, and then there'll be time for questions from the audience here in Manchester and those of you joining us online. So, Professor Paul Taylor.
Oh, that's on. You can hear me with that. Yeah, thanks. So thanks for that introduction. I have been working in AI for quite a long time. I think I've been studying it for 40 years. I'm not going to tell you very much about the first 28 years of that. Other than that, it didn't really work. But for the last 12 years, it's been quite an extraordinary journey, and I'm going to take you through some of that. I'm going to start by talking about what we call discriminative AI. I'm going to do a little bit of an introduction in a very high-level way to how it works. And I'm going to talk about some of the difficulties in bringing products based on that in healthcare to market. And then I'm going to talk about what we much more the kind of trendy thing now, generative AI. And again, spend a little bit of time on products based on that. But let's start by talking about what we mean by AI. So like everybody now, when I talk about AI, what I mean is machine learning. Okay? And this slide is meant to help you get your head around some of the concepts that are involved in machine learning. It's actually fundamentally very simple. I want you to imagine that you've got 11 patients. Some of them are diabetic, some of them aren't. And you know only 2 things about them. You know their abdominal circumference and their percentage body fat. And for some reason, you want to be able to classify them as diabetic or not diabetic on the basis of those 2 pieces of information. Well, a simple thing you might choose to do is plot on an x-axis and a y-axis, the two things you know about them, the abdominal circumference, percentage body fat. And you can see the distribution of those colored dots, and you color the diabetic ones one color, the non-diabetic ones another color. And maybe what you want to do to try and separate the two is find the line that best separates them. So you might imagine moving a plastic ruler up the page, and you can do two things with the ruler, can't you? You can move it up and down, and you can vary the tilt, okay? And you do that to find the line that does the best possible job of separating the diabetics and the non-diabetics. And that's essentially all that we do in discriminative machine learning. We have a model, and we talk about training a model. When we talk about training the model, what we mean is we're estimating values for the parameters of the model. So the model here is the straight line, and that's got two parameters, the tilt and the intercept on the y-axis, how far up the page it is. And what you're doing is you're finding the values for those two parameters which minimize a measure of error. We call that the loss function. We're always trying to minimize or maximize something. We're trying to maximize it, we call the reward function. We're trying to minimize it, we call it the loss function. And really, those are the core concepts of machine learning. Here's an example of a simple tool that we use in machine learning, another simple model. Before you had two inputs, abdominal circumference, percentage body fat. Here I've shown a range of inputs. You've got 4. And for each input, you multiply it by a weight. Right? So the weight is the parameter we're going to estimate. So you take the inputs, you multiply it by the weight, and then you add all those products together, you get the sum, and then you check the sum to see whether it's above or below a threshold. If it's above the threshold, you say it's diabetes, or whatever it is you're interested in. If it's below the threshold, you say it's not. And you try that with a load, you set the weights randomly to start with. You try it on a load of cases for which you know the outcome, and then you work out what the error rate is, and then you use that information to alter the weights to improve the classification. Okay? And it turns out that this simple tool, it looks like a neuron, so we call it an artificial neuron, is very good at learning a simple classification, like a straight line. But the great thing about neurons like this is you can put them together to make neural networks that can learn complex classifications. Right? So you can think of a complex classification as this is a bit of a tongue twister. You can think of a complex classification as being composed of multiple simple classifications. So when I started out in AI, I wasn't involved in this kind of paradigm. This wasn't my training. But I went to a lot of presentations where people were talking about these artificial neural networks in the 1980s, and they really didn't work. You could feed them a little bit of data. They could take maybe 15, 20 inputs, and they could learn a little bit, but their performance was never quite enough to be useful. There was one guy at that time who had made a bit of progress, which had to me I wasn't aware of because it wasn't in my domain, it wasn't in healthcare. And this was enabled these kinds of networks to process images. And this has become incredibly important for the application of AI in healthcare. So I'm going to spend a little bit of time talking about how this works. And the first thing I have to say is the first thing you have to get your head around is a bit counterintuitive. So when we think of images, certainly in computer science, we think of them as arrays of numbers, pixels. So if you have a bit of an image that's 8 pixels by 8 pixels, you represent it as 64 numbers. Each number tells you the level of gray at that point. That's a kind of natural way, certainly for a computer scientist, to represent an image. But you can think of images in another way. You can think of them as the superposition of simple patterns. So here I've shown you a grid of 8 by 8 simple patterns. I've shown them side by side, but what I want you to imagine them is one on top of the other, okay? And imagine multiplying each of those 64 patterns by a weight and then adding them together. Now, what I want you to accept, without me really trying very hard to persuade you of it, is that in that way, you can represent any image, right? So any image can be represented as the weighted superposition of simple patterns, like doing Fourier analysis on a one-dimensional signal. But I want you to think for a moment about those simple patterns, right? Call them basis functions, or sometimes we call them kernels. And I want you to imagine an image which is a measure of the correspondence between the image you're interested in and one of those kernels, okay? So you take your kernel and you match it against the X-ray, for example, at every point in the image, and you take a measure of that match. And that match is a number, but it's also corresponding to a point. So you create an output image, which represents the strength of the feature at that point in the image. So imagine a neural network where the tunable parameters are the pixel values in a set of kernels, right? So when you put your input image in, you move these kernels over it and you measure the outputs at every point to create a stack of feature images. But the feature images that you create are determined by a learning process because the values of the kernels are tunable parameters. So you train the network to extract from the image exactly the information it needs to make the decision that you're interested in. And this was done really quite early on, in the late 1980s, by a man called Jan LeCun. And he was able to classify handwritten digits well enough to be able to read postal codes for the American Postal Service. So really quite astonishing successful application at that point, but it didn't really go further. In fact, all of this seemed like a bit of a dead end until a moment in 2012 when a PhD student called Alex Krapitsky stood up in front of an audience in a room about this size and spoke through 28 PowerPoint slides. And that completely changed the world. You can see that when that presentation was written up as a paper, and it's been cited 133,000 times, right? This is an extraordinary high piece of impact research. And what he's told people was that he'd won that year's ImageNet challenge. He'd not just won it, he'd blown away the competition. And the ImageNet challenge involves classifying over 1 million images into over 1,000 categories. And these are categories like pizza, skateboard, llama, mandolin. So if you can classify all of those images, and they're just images downloaded from the internet, and you kind of, you're getting at solving the fundamental problem of vision. And the really astonishing thing for the audience was that he'd done this not with some fancy new technology. He'd done this by using the convolutional neural networks that Jan LeCun had developed decades earlier. But he'd been able to make them work for two reasons. One, he'd had access to data on an extraordinary scale through the ImageNet challenge, over 1 million images to train his algorithm on. And he'd had the computational power to do it. And you need to perform those kind of computations at the scale they were doing. You need specialist hardware. But you can't afford to build specialist hardware. It's incredibly expensive. But the specialist thing you need to do is matrix multiplication. Training a neural network is essentially matrix multiplication. And there's something else which is essentially matrix multiplication, and that's the computer graphics in gaming consoles. So they used the chips from gaming consoles to program neural networks. And after that, everything went mad. This is the share price of NVIDIA, the company that sells those chips, the graphical processing units. And this was not an unsuccessful company in 2012, right? And it's now the largest company in the world. And you can see what happened after AlexNet. AlexNet had 8 convolution layers. Shortly after that, another team won the challenge with a network with 19 convolution layers. In 2016, Microsoft won it with a network that had 152 convolution layers, right? ResNet. And that's kind of the state of the art now. Things haven't really got better than that. But this is the beginning of 2012 was the beginning of this extraordinary hype cycle. And by 2016, it looked like the problem of vision was essentially solved. The humans performing this task make an error rate of about 5%. ResNet is 3.6%. So this is doing that task of classifying natural images as well as human beings can. So no wonder people thought, this is going to have a huge impact across a range of real problems in the real world. Spoiler alert, radiologists are still around, right? So in 2016, I don't know if they were inspired by Geoffrey Hinson's remark. They probably were, it's probably complete coincidence. But in 2016, a UK company called Kira Medical Technology was founded. This is the submission at Company's House. And they wanted to apply AI to breast screening. Now, I want to spend a minute or so explaining why breast screening is a particularly good application for this kind of technology. So what happens in breast screening? It's a huge public health endeavor, right? 2 million women a year are screened for breast cancer. And at the screening visit, they'll have 2 views taken of each breast, so there are 4 images. And each of those images is looked at separately by 2 highly trained professionals. They may not necessarily be a radiologist, but they're highly trained professionals. And then if either of them thinks it's suspicious, it will be reviewed at an arbitration meeting. And then if it's deemed to be sufficiently likely to be cancer, the woman will be recalled for further tests. If not, return to routine screening. So there are lots of ways you can introduce AI into this process. You can give it as an aid to one or both of the radiologists. You could maybe say, well, actually, maybe the radiologist plus the aid is so good, we can get rid of the second radiologist. You could maybe use it to completely replace one or other or both of the radiologists. You could add it as a third reader. You could introduce it as a triage step in advance. There's lots of things you could do. But I think it's absolutely the right thing to try and do with AI because it's a really simple binary decision, yes or no, that's taken on an entirely circumscribed piece of information, the image. It's a difficult decision. The image is very complicated and it's complicated data, but that's all there is. You don't need to know anything about the woman's social history. You don't have to have any empathy. You don't need to have any of the things that machines find difficult. You're just making a simple decision. Do we need to restore this person or not? And the later care is more complicated, but the screening decision seems eminently automatable. And Kieran did astonishingly well. So they were founded in 2016. By 2018, they'd already got regulatory approval. So they'd already convinced the regulator with empirical evidence that their product was as safe as a radiologist at interpreting images, right? They haven't published that data. So I don't know exactly what they did to convince the regulators. But some years later, not many years later, 2021, they published a major retrospective study that showed that they were effective and as effective as radiologists at interpreting cancer, detecting cancer on mammograms. That study, interestingly, has not been peer-reviewed. Right? I've seen it, it's up on as a preprint, but it's been a preprint since 2021, quite a long time, so I'm not sure what's going on there. And then in 2022, after they'd published their major retrospective study, the National Screening Committee said, we don't care about retrospective studies. We need prospective studies in order to demonstrate that these things are safe and can be used. So, and Kieran Medical has to go on and do a prospective study, which they've started. I've seen earlier this year press releases saying that they got positive results from this prospective study, but I've not seen a journal publication. I don't have any information beyond what I've read on BBC News about it. They have done a prospective study in Hungary, but it's a slightly weird one because it's of the use of the algorithm as a third reader, and no one really wants to do that because it doesn't save you any money. You might detect a few more cancers, and that's great for the women who benefit from that. But really, in order to introduce a technology like this, you need a business case, and that isn't your business case. But after that, in parallel to that, the screening committee has been talking to HTA and saying, actually, we need more evidence. We need to commission a further prospective study. So they are currently awarding a contract to a group of researchers to do a further prospective study before the technology can be introduced to the screening program. And in the meantime, last month, Kieran has been sold to a radiology provider in the States. And maybe that was always the plan. I don't know. But it seems to me that it's possible that an indication that they were running out of money because they've been around spending venture capital money and what NHS research grants they've been able to get since 2016. And they will have burnt through a lot. Here's another example. This is in diabetic retinopathy, a different screening program. A company called Inox that was founded in 2010. Their product was CE marked for use in the EU, including the UK in 2015. I was involved in a HTA trial of it in 2016, which showed it was safe and cost effective. We were told that was a retrospective study, it's not good enough. We then did a prospective study, and that again showed it was safe and cost effective. It was more safe and more cost effective because it was a better algorithm, right? Because the algorithms get better all the time. In 2021, and this is really confusing, I find this really confusing, the National Screening Committee commissioned a group of experts to review the evidence. The group of experts says, well, the evidence is that it's safe and cost effective. And then the minutes of the meeting at which the evidence was presented, I wasn't at the meeting, this is my understanding from reading them, concluded that although the evidence was it was safe and cost effective, there wasn't enough evidence that they were safe and cost effective, given that there was uncertainty about value for money and the social and ethical aspects. So there needed to be more research. And it's the third example, my last example. This is not screening, but it's something similar. This is chest x-rays. The whole AI company launched in 2017. They produced an algorithm. They got regulatory approval. They produced studies showing that it worked. But they weren't brilliant studies. They were small-scale studies, question there. But their problem was that their business model was telling the hospital that some of the x-rays were so clearly benign, so clearly no sign of malignancy, that they didn't need to be looked at by a human. But the regulations that govern the use of ionizing radiation don't allow hospitals to apply ionizing radiation to humans without the exams being reviewed by a human. So the company would say, we're going to automate this for you, we're going to use AI. But in order to avoid breaking the law, they actually had to employ radiologists to look over the films themselves. And that's not a viable business model, and they went bankrupt last month. So there are lots of questions here. So one question I think is what's the amount and what's the kind of evidence we need in order to put AI into practice? So the reason, and one of the things that's come up in looking at the thinking of the screening committee is that they don't like retrospective studies, they like prospective studies. The AI doesn't behave the same way, right? The AI doesn't know whether this is a current image or an old image. So it makes no difference. The difference is in the behavior of the human. Right? So the human radiologist using AI will behave differently in a retrospective study because they know it's an experiment. So the screening committee says, well, they have to be doing it in real life. They have to know it's a real patient. Otherwise, we can't trust the results. And I think that's fair enough, except that radiologists are humans and they're susceptible to lots of influences. So it's not actually obvious that their behavior with this version of the software at this point in time is going to be the same as their behavior with the next version of the software in 2 years' time. So I'm not sure that we're actually learning anything and waiting 2 years. I think the screening committees are being a bit conservative here. Just a few more things about how am I doing for time? That's good. Right. Okay, well, about halfway through. So this is a cost-effectiveness study of Kieran. I think it's worth looking at because sometimes when you hear the politicians talk, they talk as if once AI can do it, that the NHS is going to get it for free. But a company that's been burning through tens of millions of pounds of venture capital for years and years isn't going to do it for free. So this cost-effectiveness study was based on the assumption that Kieran would do it for £4.72, whereas a radiologist, a human, would be doing it for £5.90. So if you're thinking AI is maybe a bit risky, maybe you're not going to think there's enough of a saving there. It's a bit equivocal, isn't it? It's not as cheap as chips. And the other thing to bear in mind is that radiologists, they're not, I'm not saying they're badly paid, but they're very fast, right? So for this screening decision at a sort of per film basis, they're pretty cheap, right? £5 is not a lot of money. The thing that costs money is if you end up recalling more women from screening for further investigations. So a tiny shift in that, what we call specificity, could end up being incredibly expensive compared to these marginal gains of a pound and a few pence. Meanwhile, as I said, Kieran has been sold to I wasn't talking about Kieran. Kieran has been sold to an American radiology provider. And in America, similar to here, the regulators say it's fine, you can sell it, it's safe. The insurers, people who control the purse strings, say, no, we're not reimbursing this. So at the moment, if you want to have AI read your mammogram, you have to pay an extra $40, which is more than the sums the NHS was talking about. But I think despite these delays, there is a momentum building up. So there are 949 AI-enabled devices that have got FDA approval at the moment, and 723 of those are in radiology. So it's overwhelmingly radiology that's been targeted by AI. Most of those are from the major imaging suppliers, companies like GE, Philips, Siemens, and so on. But there are a few small AI-focused startups which are making waves. And two I picked out are Quare, which is an Indian company, and Analyse, which is Australian. And they're the ones that are winning the NHS contracts at the moment. So they're the ones which are getting their foot in the door. And compared to the companies I talked about, which have struggled and maybe in some cases gone under, they've got quite deep pockets. because they've been backed by very substantial amounts of venture capital. So I talked about discriminative AI. I started with an event in 2012. The big events that led to the boom in generative AI was really 2017, when the guys at Google published a paper with the sort of humorous title, "All you need is attention is all you need." And you may not have heard of transformers, but you'll have heard of GPT, and the T in GPT stands for transformer. So what transformers do is they implement what we call in machine learning an attention layer. And an attention layer is kind of does what it says. It learns where in a sequence you should be focusing in order to best accomplish the task that you're trying to learn, right? So it learns where to focus. And I'll talk about why that's really, really important in generative AI. So we're going to think about a kind of neural network that's different from the ones I talked about before, because instead of learning, having as its output a decision, it has as its output the input, right? So it's learning to try and reproduce the input. So you're altering the weights to minimize the difference between the output and the input. And you think that's a kind of weird thing to do. Why do you need to generate the input? Because you've got the input already. The reason you do it is that if it learns how to do it, then this middle layer, this middle layer, this what we call the bottleneck, is a succinct representation of the problem space. I'll give you an example of how this might work. This is a picture of Michael Spence, the provost of UCL. Imagine that it's 1,000 pixels by 1,000 pixels, so it's 1,000,000 pixels of Michael Spence. Think of each pixel as a dimension, right? Because it's a number, right? So it can be a dimension. Think of a million-dimensional space. Don't think of a million-dimensional space, it's really hard. Think of a three-dimensional space and pretend it's got 1,000,000 dimensions. That's the way I do it. So one point in that space contains all of the information in that photograph, right? So 1,000,000 pixels can be represented as one point in a million-dimensional space. Now imagine I got photographs of all of the vice chancellors and all of the provosts, all of the leaders of all of the universities in the world. I wouldn't have that many, but I'd have a couple of thousand. So my space, if I put all of them into that space, would be largely empty. But what I could do is I could find a smaller space within that space. So imagine that I took a straight line that went as near as possible to as many as possible as the vice chancellors. And then I drew another line that was constrained to be at 90 degrees to that, and then another one. And I did this until I got maybe 10, 50, or 100 dimensions. I would now, instead of having a 1,000,000-dimensional space, I would have a 10, 50, 100-dimensional space. And my pictures would be distributed within that. And if I was lucky, that space would represent something fundamental about the kinds of things I was looking at. So that if I took another sample from that space, it would look like a vice chancellor. But it wouldn't be a real vice chancellor. It would be a generated vice chancellor, a synthetic vice chancellor. I didn't actually get around to programming an algorithm for generating synthetic vice chancellors. I just looked at a website that had it's called "This Person Does Not Exist" and took an image from that, right? So this person does not exist, right? This is not a face. This is a random sample from a computer-generated synthetic space, if you like, space. So this is what we do in generative AI. We learn a representation of a space, and then we generate samples from that space that are new things. So in language, we start with a mathematical representation of meaning, which is derived from looking at statistics of the use of words. Okay? This used to worry me, that the basis of these things was not, they didn't know anything about cars, they just knew how the word car was used. But that doesn't really worry me anymore, because I think there's probably very little you need to know about cars which isn't written down somewhere on the internet. So models which abstract everything that's written on the internet probably learn everything you need to know about cars. Then you have this attention layer, which works out where in sequences, in very, very long sequences of words, not just sentences, but whole books, you need to focus attention in order to learn an artificial task, this kind of autocomplete task. And so that means that they're abstracting deep kind of semantic meaning from these sequences and learning kind of real truths about the world. And then the chatbots, the chat GPTs, are actually also trained by what we call reinforcement learning with human feedback. And that means that essentially that a human is looking at the output and saying, this is good output, this is bad output, this is good output, this is bad output. And these people tend to be very poorly paid and they tend to be working in parts of the world where you can get people to work for low wages. And one of the things you find is that in those countries, English is slightly different to the English that we are used to in this country or in the United States. And so you will find words in the output of generative AI which are slightly more common in the output of generative AI than they are in other forms of language. So, for example, this is a graph of the frequency with which the words del and underscore co-occur in academic publications since ChatGPT became widely available, right? So if you're in the business of marking assignments and you find that these words are occurring more often than you might expect, maybe generative AI has been used, or maybe it's because your student is not a native English speaker, right? These are not easy decisions to make. This is a logarithmic graph on a logarithmic scale. So it's showing the increase in the size of the models that are being used in AI. So you can see that the scale is just unbelievable, right? And this is sometimes called the bitter lesson of AI. We haven't achieved enormous progress by clever algorithms and thinking of new ideas. We've achieved it by doing things at a bigger scale, spending more money and more of the planet's resources. And these are graphs from a team at OpenAI showing the correlation between performance of their models. It's slightly unintuitive because what's on the y-axis is error, so descent is good. And what you see is as they get better, as they get bigger, they get better. It's not exponential. These are power law relationships. So the achievements are obtained at the cost of incredible increases in the amount of compute and the amount of data. But people sort of believe that what's called the scaling laws, you just need to keep getting bigger and progress will continue. But I'm not entirely sure about that, partly because I'm not entirely sure that there's actually scope to get much bigger. And it's interesting that the version numbers of GPT haven't been accelerating the way that people might have anticipated when they released GPT-4. But also, this is quite a discussed graphic from a presentation, and it shows that as you increase the scale of the network, some capacities seem to emerge spontaneously. And people got really excited about this, that you just need to build the networks bigger and these capacities just appear. You know? And like maybe if you build them even bigger, then even more exciting capacities will emerge, like consciousness. But actually, the y-axis here isn't a ruler. It's something more like a GCSE maths test. So it may be just not very sensitive at the bottom end, right? Because so maybe this apparent uptick is actually an artifact of the measurement process. And there was a paper last year that seemed to show that was a viable hypothesis. I've just got a couple more slides. Just want to advertise some of the work that colleagues have been doing at UCL in the PhD center that I'm the director of. And this is an approach called RetFound, which is doing something similar to the GPT models in that it's training a model on a huge number of images in order to create what we call a foundation model that can then be customized for different tasks. And one thing people are particularly interested in is that ophthalmic images can be used to predict systemic disease, like cardiac disease, like Parkinson's, because the eye is a kind of window onto the circulatory system. This is an initiative called Foresight, and there they take patient histories and they turn them into sequences, right? They arrange out all the events that have happened to a patient in sequence. And a bit like you do with computer models and autocomplete, you try and predict what will come next by feeding it into a transformer model. And it sort of works, but so whether it will really work or not, we don't yet know, but it's something which is an incredibly exciting proposition. They're training a foundation model on electronic healthcare record data from our partner hospitals. And lastly, this is quite a simple piece of work done by a PhD student attempting to use a large language model to generate discharge summaries from patient data. So this is a task which is currently a lot of work for junior doctors. And if you feed the large language model a prompt which includes not just all of the patient data, but also the Royal College's guidelines for what should be in a discharge summary. And then you get it to generate the discharge summary and then review that by clinicians. And it's not quite good enough, but it's an interesting approach. But I don't know how much you know about electronic healthcare record markets. If you're resident in Manchester and you're a patient at a Manchester hospital, you will be a customer, if you like, of Epic. Epic is also the system that's in use in the hospital I work with, UCLH, and at Great Ormond Street, and at Addenbrooke's in Cambridge, and increasingly at other hospitals in the UK. They own 85% of the market in the United States. They're incredibly profitable. They have a lot of money. At their campus in small town America, I can't remember where it is, it might be Wisconsin, they employed 3,000 or 4,000 software engineers. And the campus looks more like a theme park than a place of work. And they have extraordinary amounts of money to spend keeping their employees happy. Their canteen looks like the Harry Potter version of King's Cross Station, and it's just mad. But they are introducing 60 AI applications into their electronic healthcare record as we speak. And these are intended to make doctors more efficient and productive. So these are productivity tools. So the question is, do these tools have to be regulated in the way the software I was talking about in the first part of the talk does? And Epic says no, right? But this is a view from a consultant who works in the space, Hugh Harvey, who runs a consultancy called Hardy and Howe. And he says, well, actually, if you look at, from the UK perspective, for example, if you look at the guidance document for medical devices, software which is intended to create or modify medical information might be qualified as a medical device. If such alterations are made to facilitate the perceptual or interpretive tasks performed by the healthcare professionals when reviewing medical information, the software could be a medical device. So something which is generating a discharge summary, for example, maybe that would require regulation. And actually, software tools based on large language models will be incredibly difficult to get regulatory approval for. OpenAI don't want to expose what they're doing to the regulators. They don't want to tell them how the models are built. But if your software depends on their software, and the regulators say they do want to know how it works. Also, intrinsically, large language models include an element of randomness, right? So it's quite hard to imagine the regulator being entirely happy with that. So if these tools are classified as medical devices, then I think they probably won't get approved. So you will have to have a slightly different process, maybe building a large language model of your own from scratch, specific for that, the process you have in mind. But that's tricky because you're competing against people with very, very big pockets. So whether you could get something that people will be happy with is another question. This is my last slide. So final thoughts. It's proved surprisingly hard to get AI into successful products and to get those products into the NHS. I don't want to argue that we over-regulate. I think regulation is incredibly important. But these are products that the regulator has approved. So my argument would be that maybe that's the bar, that's where we should set the bar. And maybe we shouldn't be putting too much evidential burden post-regulation before the products are put into use. So maybe I think the screening committees are possibly being a bit conservative, although some of them are my friends. And my final point is that I think that the tools which we're seeing, such as the ones that Epic is producing, which are based on the use of large language models, may be really difficult to regulate. So the question will be, are they safety critical? And I think that's quite a hard one to answer. I think you could make a case that something that's generating a discharge summary is safety critical. But then I think there'll be lots of productivity tools which are AI-based, which doctors will rely on. And I think if you just say any or all of those are safety critical, and all of them there's some level of risk, and maybe the level of risk is acceptable. It's hard to know. Okay, thank you.
Thank you very much, Paul. We are going to have time for questions now. We have also an audience joining us online. And if I get people over here waving at me, That means we will have some questions from online. We also have a couple of folk running around with microphones. So if you want to ask a question in the audience, and I'll go to the audience first, please do put your hand up and wait for the microphone to come to you. And it would be great if you could just briefly introduce yourself and where you're from. So obviously, if you're a radiologist, I'm really keen to hear from you, first and foremost. But have we got any questions from the audience? So we have one over here. Thank you, lovely.
Hi, Paul. Chief of Staff, Centre for Health Informatics. Very interesting. I have a question about generative AI, and especially the AI that uses internet data to train itself. Given the fact that more and more content on the internet is AI generated, chatbot generated, is there not a huge risk that ChatGPT will increasingly learning from the crap they created themselves?
That's a technical term, isn't it?
Yeah, no, I think there is I think there's a real danger of that. But my guess is that they will have to find a way around that. It's interesting. I think I didn't really. I felt maybe I skipped too quickly over the slides about the scaling laws, but there was a sense that you could just keep on going, keep getting bigger, and the algorithms would get better to the point where they were comparable with human level performance. And I think it's possible that will happen. I don't obviously. I've been earning a lot more money than I am if I knew the answer to these questions. But it's possible that it won't. And I think one potential sort of stopping brick wall they might hit is that the energy requirements just get too great. And obviously, listening to Dennis Hasidius give talks recently, he obviously feels that this is a challenge that Google can meet, but it's at the edge of what they can do. It's a huge engineering challenge, making available to the AI programs, all of the servers they can muster from all of their outputs around the world in order to do this. But the other bottleneck they reach is they run out of data to input, right? And that they are pressing at the moment, I think, just about everything. So if that gets added to, but doesn't get added to in terms of stuff that's got new information in it, just regurgitating the old it, yeah, it won't be of any help.
Thank you very much. We're going to take a question online, I think. So, do we need the mic? Oh, okay. I haven't worked this out perfectly, but then we will come to the lady in the middle and the gentleman here who has just given back the microphone. So Catherine's going to read out a question from someone online.
Yeah, so I'll combine two questions into one. So, firstly, could you give us an example of one or two areas where you think that AI should absolutely be used in healthcare? And then on the other hand, where it should never be used?
So I think that the screening application is the right one, where it's a simple decision and there's no kind of human context. It can be solved algorithmically. There was an interesting study where somebody trained pigeons to do it, because it's not actually a task when you think about it that really requires you to have gone to medical school, because you're not actually using any of that knowledge. I mean, obviously, at other points in the process, and maybe it's helpful to have the person who's involved in other points in the process making that decision too. But it's a difficult task. It's perceptually challenging, but it doesn't really require anything other than pattern recognition. So I think that's the right kind of thing to be using AI for. What you shouldn't be using AI for, well, it's stuff that it's not able to do. And there are lots of things at the moment that it's not able to do. So it's one of the things that worries me, I think, is its use in mental health. So you've got, I think there is potential, but I think it's very difficult to be confident that it's safe, that it can replace the human. And I think if you've got services which are stretched, you can imagine a situation where people think, well, this is maybe good enough. So I worked in trials of computerized CBT, and they were effective and seemed to be helpful for things like smoking cessation or kind of sort of low-level behavior change problems, where people couldn't access what we know to be more effective, the actual engagement with an active human being. But then you think, well, we will get into a situation where the services get so stretched that people try and automate more of the kind of mental health services. And I think that would worry me. I mean, you don't want to be too much of a Luddite, because actually there are some advantages to doing these things. I mean, some people prefer not to have the contact with a human being. They find that difficult. So they can get the help by interacting through a screen, then maybe that's a good thing. But I think that the danger is it's just so hard with the things that are language-based to demonstrate that they're safe.
Thank you. We'll go to the lady in the middle and then back to the gentleman here who gave up the microphone.
Hi. I'm not a radiologist, but I am a historian of medicine. Sorry. And what I found really interesting about this talk, I think really fascinating stuff. The images that you're talking about here are some of the ones where the people who make the images, the people involved in mammography and other kinds of screening, are some of the most expensively trained people working to produce consistent kinds of images and a consistent input. And so I guess I was wondering, does AI essentially shift the burden in the system to force us to have more consistent input that can then be analyzed in a way that may not be workable for, say, internal medicine on the most part, but may work very well for screening and for other things where we can get it down to a set of data points? I'm thinking about, I know from reading how much work had to be done to train people to take samples and to take mammograms in a consistent way. And that in some contexts, the UK has pretty good quality mammography, but not all contexts do. They don't have as good quality of input as we do. And I guess I'm wondering, do you see any issues around where the labor shifts and how we maintain quality control in getting the data into the system in the first place?
Yes, so there are some issues there which I think I might struggle to answer. But two thoughts come to mind. One is that the algorithms can be very susceptible to shifts in the input. So when we did the work I mentioned briefly, looking at diabetic retinopathy, we were working with an American vendor, and one of the American vendors was very disappointed with the quality of the UK images. And it actually wasn't a difficult problem. There was just more dust, and it's very easy to remove the dust. It's a very simple algorithmic step. But if you hadn't done that, then it would have created a problem. So it may be that an algorithm that's trained on images from the UK, if you then send it to a different country where the technique isn't as rigorous and you've got more what the UK would consider to be poor quality images, it struggles. So yes, absolutely, that's an issue. In terms of what it means for the workforce, I think there is an ongoing process of automation, and I think that's affected radiography. So some of the skills of the radiographer are no longer required because the devices will change the setting automatically. But that doesn't mean that radiographers become unskilled. It means that the job changes and the skills that they need change. And I think that will happen perhaps faster as the machines get better.
Thank you. We'll go straight to the gentleman here. We've got a couple of questions here down here at the front, if you can come down.
Thank you very much. You partly answered my question around the area where you thought it was quite risky, because this is one of the questions I was focusing on. Is your belief about whether we actually have the ethical, we've talked about the challenge of ethics, the ethical frameworks that underpin the drivers which are moving this forward? I'm a nurse by background. I've been lucky enough to do some work and be out in Santa Clara with a range of different companies who are all seeing health as being the big panacea, the big investment area going forward. But they're being driven, and their investment is coming from very much the entertainment energy. So you've talked about these layering of images. We're able to now develop 3D images to make people look like they're at a Coldplay concert. And we also have chatbots in mental health. Now, we've spent years as a profession developing our regulatory safeguards or ethical safeguards, developing trust tools to measure the relationship between a psychiatrist and the patient. What I haven't seen, I was just wondering whether you feel that our ethical frameworks are developing fast enough to deal with the commercial drivers, which will drive the cost down. At the same time, the demand for us to have AI in healthcare will increase. But there seems to me this pressure point there, ethically and regulatory, and whether you have any view on that.
I'm not sure I've got things well worked out for you. I think it is really hard. There is an awful lot of attention going into the regulation of AI. And a lot of that is based on trying to prevent inappropriate use of AI. And so from the EU perspective, for example, it's about the same kind of guardrails which you put in place in other kind of product regulation to make sure it's safe. And I think one of the ethical concerns that I have is that a lot of the intended applications of AI are doing things which will have unforeseeable consequences in terms of major upheaval, in terms of major categories of employment disappearing. But it's just so hard to know, how fast it is actually going to deliver that and how far it actually gets. So I kind of sympathize with people not wanting to regulate too hard and too fast when things are so uncertain. I think in the healthcare environment, we have a strong regulatory framework anyway, things which are classed as medical devices. The worry, I suppose, is where things are able to avoid regulation of medical devices. I mean, one thing I didn't talk about is a company called Babylon. People heard of Babylon?
Yes, yeah.
Yeah. So Babylon, I mean, in some ways, it's not a good example because the guy was basically a crook.
Okay, but apart from
But Ali Parsa, fantastically charismatic figure, was able to attract extraordinary amounts of venture capital for a company which produced really interesting technical work. But the technology didn't really affect the business plan. And the business model was that you would give people an app on their phone, which they could then use to access a doctor when they felt they needed a doctor. And the app was actually given away for free because they were able to make money by earning the capitation fees. Because when you used the app, you became a patient at a practice in Fulham, in fact, and they had a deal with Fulham, so they collected the capitation fees. And GPs were very angry about this because they felt that the company was cherry picking young, tech savvy people who probably weren't that expensive to manage. And actually, the local NHS obviously really struggled because they suddenly found they were having to pay for the care of 200,000 people who basically live in the borough. But actually, the AI was meant to triage the calls and save money, but it didn't really work. And what happened was that the company messed up because it turns out if you give people an app that enables them to contact a GP really easily, they contact the GP. Even if they're healthy, young, tech-savvy people, they were calling the GP as many times as the average NHS patient. So they had to hire extra staff, extra GPs to man the phone lines. In the end, they went bankrupt. So when they went from being a company valued at 4 billion and being Matt Hancock's favorite thing to talk about to make them look tech savvy to bankruptcy in a matter of months. Absolutely extraordinary.
It is a great story. Another great story is we already have 5 questions more and we have 5 minutes. So we have a challenge now, both for questioners and most in particular for Paul here to give really quick answers. So we've got a couple of questions down here at the front. Then Catherine is going to give us a question from online. We have one right back in the middle and we have a gentleman here as well. So go, Paul.
Okay, Paul Dark, Faculty of Biology, Medicine and Health. Focus question around healthcare inequalities. How can AI protect us from driving healthcare inequalities and inequalities in healthcare outcome, or is there a danger in AI that we will progress it further?
There is a danger, and there is also, I think, hope, because I find that certainly among our PhD students, there's a real motivation to make sure that AI is made as safe as it can be. There's a real enthusiasm for projects based on AI and fairness, but it's a challenge, and whether that enthusiasm for the people I mingle with is reflected in the boardrooms of the companies that are producing the software, that's a harder question.
Thank you. Kieran, and then I will bring the mic over. Don't worry about that.
I'm trying to be really quick. So a lot of the examples you gave were using AI to replace a very established and existing traditional pathway, your mammography screening example. I'd be interested to know to what degree you think AI actually provides the opportunity to completely change the pathway. So if I take an example, that mammography one, rather than taking the x-rays of somebody and then sending them off to be examined, in real time, you could be taking x-rays, using the AI to help read those x-rays, and then taking further images to be more discriminant in your judgment about whether or not somebody has a cancer. And that's not what we traditionally did, because we didn't have the radiologist and the radiographer in the same room. The AI could let you put all of that in one place.
So I think there's an analogy, isn't there? So when computers were first introduced into industry way back in the 70s and 80s, they tried to computerize the existing processes. And then actually people thought, well, what we should be doing is looking at what is possible given that we have computers and designing new processes. So you could imagine that there would be some ways in which you could imagine something like a device that takes images of the eye, which you could just give to patients and they could take frequent images at home. And then you would get an unworkable amount of images generated, but they're interpreted by AI, so it doesn't matter. So you could have completely different ways of managing conditions based on technology that doesn't exist yet.
Catherine, anything from online?
Yeah, we've got a question from a computer science undergrad who's looking to work in this field. And so what would your advice be in terms of getting into this field? Would it be joining the NHS graduate management training scheme, doing a master's in AI, taking a data science job at a healthcare company?
Well,
As an academic,
as the director of one of the AI-focused specialism of the graduate management training scheme, I'm going to pitch for that. It kind of depends what you want to do, I think. If you want to, if your interested is in developing new products, then maybe get a kind of PhD level training in AI and then pivot from that into a company that's doing the most exciting cutting edge work. But there's also really exciting roles, I think, in applying the technology at the moment. And that's the kind of role that the graduate management training scheme would end up in.
Martin, and then the gentleman over there, and then we'll come back to this gentleman here, and then I think that might be everything, ladies and gentlemen. So, Martin.
I represent patients in various committees in the NHS. I'd like to know whether you think we can evaluate the relative risk of human beings as opposed to AI, because there's an assumption that radiologists don't make mistakes. Well, I'm sure they do.
Yeah, they do. Yeah. Yeah, the AI doesn't have to be perfect. It just has to be better than the human. But the radiologists are very good. So the people, I think, have been surprised at how hard it was to equal radiologists before it. But I think they're there. Yeah.
Next one, gentleman in the middle with the glasses.
So, Professor, I wanted to ask you, amazing potential with AI. Question number one, would you classify our brain as AI? And secondly, if AI, machine learning, is going so fast, do we need to do brain learning to keep up with it? Just like machine learning, do we need brain learning to keep up with it?
I don't think I'm going to keep up with it. Feel free to have a go. AI is not like us, I think. I think that's my answer to your first question. It's incredibly impressive, and it does what it does really well. And I use this a lot. I have conversations with ChatGPT. I ask it to generate computer code to help me get started on projects. But it's not. It doesn't do what I do. It doesn't work the way that I do. It's not the same. And I think how we kind of co-evolve is a really, really big question that I wouldn't dream of attempting to answer.
Have we got another question at the back? Okay, we'll come to that one in a minute. I want to give this gentleman a chance here, and then we'll absolutely have the last question up there. So,
thank you very much, Paul. Very quick one. To what extent do you think that academia can work with private enterprise at the rate of change that we're seeing? This feels like a graphene moment, given that we're in Manchester, right? And you look at the OpenAI and the private enterprise and the large language models, and we have an AI MVP, but trying to find the door with institutions and people like Manchester is very, very difficult.
Yeah, so I read a really good book recently by Fei Lee, who's the woman who invented the ImageNet challenge. and it's called The Worlds I See. And she was a professor at Stanford researching in AI, and she realized that Stanford, which is not a poor university, they could not compete with Google. So they were using kind of, clusters of large, what we would consider a very large cluster of GPUs, but Google had 10 times, 100 times more. So she left and took a sabbatical at Google and worked at Google for a while. But when she finished her sabbatical, she came back to academia because she felt, although academia can't compete with industry, it doesn't have the resources, it's not anything like the resources, it does have a role. And it's particularly around educating the next generation. And it's about instilling in them the values that we want them to have as part of that education. And it's about addressing challenges like bias and fairness. I think that's our role.
Thank you. And finally,
Yeah, so I just wanted to ask, so far, so I'm an undergraduate right now. So far from my schooling career and my undergraduates now, we've had this kind of stigma that we shouldn't use AI at all, or we should use it very minimally in our learning, and we should do everything by the textbook or by the book. Now, I just wanted to ask you, as a professor in AI, to what extent, how much should we use AI to facilitate our learning? And do you think so I study medicine, for example, a lot of it is just learning a lot of content. And I think so far what I've used for AI, it's been very useful in condensing that information. Whereas when I go through a textbook, it's all over the place and it's very hard. Do you think that's an acceptable use of AI? And do you think in that sense, would you recommend using AI for these types of things?
Yeah, I would definitely recommend using AI for things that it's good at. The danger, I suppose, is that you become lazy and you use AI to do the exercises which are put there to challenge you and to make you think. So my colleagues who teach programming, for example, are very keen that their students don't use AI. So they set them tests which they know AI can just solve it, like that. But they make the students do it without AI. We're going back to old-fashioned exams in order to force students not to have access to these kinds of tools. And my colleagues say, well, we have to do that because they have to learn it. And only then, once they've learned it, can they then make effective use of the tools. But I wonder, right? Because obviously it's sort of the easy answer, really, from my colleagues' point of view. And I think what the right thing to do would be to work out how to make the most effective use of the tools and what skills the human needs to have in order to make effective use of the tools. And then you teach those skills. Problem is we don't have time to do that, right? Because actually my colleagues who are teaching programming, they're academics, they're not programmers themselves. So their knowledge of what you can do with the tools is sort of secondhand. I think it's a really hard problem. But, and I think I want to be honest with you and say I'm not sure that we've worked out the best way of confronting it. Because I remember when ChatGPT first came out, I gave a presentation on it to my colleagues, and I was saying this is the logical order in which we need to do things. We need to work out what the tools can do. We need to work out what the skills that they need to be learned to live in this new world where these tools are available. And then we need to work out how to teach them. And then we need to work out, what the assessments are. The problem is we have to set the assessments next month. So let's just do the whole thing backwards, and maybe we'll never get to the really deep, interesting question. We'll just solve the urgent questions as best we can. Well, but I think, actually, there's quite a lot of literature coming out on, because I'm interested in teaching AI to medical students, right? So we're starting doing this at UCL, and I'm trying to reach out to colleagues at other universities to share expertise. So we run a first-year module on AI to medical students, and I work at what it is that they need to know, but also what is AI going to change what they need to know about the rest of medicine. But actually, I think most people who are looking at AI in medical education are thinking about how can we use AI to better educate doctors by building more interactive learning tools for them to use. There's a lot of interest in that.
Thank you.
Thank you very much. And I'd like to just do some thank yous as we come to the end. And thank you for allowing us a few more minutes over the time. So I want to thank colleagues in AV and marketing who have helped do all the work behind. So the colleagues who've been running around the microphones, Becky, who's not here today, and Catherine, who have helped us with promotion for this event. To you, the audience, both in person here in Manchester and online, thank you very much for your contributions. And finally, to Professor Paul Taylor for giving this year's Kelly Chester lecture.
It's been great. It's been a pleasure. Thank you. Awesome.